In this video, a medical oncologist and radiation oncologist discuss the treatment of unresectable Stage III non-small cell lung cancer with a focus on Stage IIIC disease. In your practice, for patients diagnosed with unresectable Stage III non-small cell lung cancer, how do you coordinate care?
One of the things that's been very helpful is starting a thoracic-focused multidisciplinary tumor board. It's really helped us iron out some kinks and identified some problems that we didn't know were present before that. Even in the absence of a lung cancer-specific tumor board, I would just point out that communicating between the medical oncologist and radiation oncologist for every Stage III patient is vitally important as you set up the right treatment package for the patient.
So in my experience, it helps with the continuity of care when these patients are in the hands of both medical oncologists and radiation oncologists. So we're seeing them together from the get-go. And of course, once they're with us throughout this entire process.
In your practice, which patients with Stage III non-small cell lung cancer do you consider appropriate for curative intent treatment?
I would say for the most part, I'm seeing all of these patients or certainly closely reviewing them with my colleagues in medical oncology. Anytime a patient is Stage 3, whether that's Stage 3A, 3B, or 3C, they're potentially appropriate for curative intent therapy, and we want to make sure we've thoroughly considered that option.
The bottom line is when we're looking at these patients, it depends on tumor bulk, number of nodes, age, pulmonary status, and whether the patient is a surgical candidate or not based upon performance status and comorbidities. And of course, sometimes it's not 100% clear. As I would like to say, it's a little bit of everything in these discussions that goes into it, which is why it's great to have everybody look at the case together.
Now let's consider the following patient with unresectable Stage IIIC non-small cell lung cancer. A 55-year-old male who is a current smoker presents with weight loss and shortness of breath. The patient has COPD, but otherwise is in overall good health. In your experience, would this patient typically receive curative intent treatment?
As a radiation oncologist, we always need to look at the images and see what has made the patient Stage IIIC. We want to make really sure that the patient's had a thorough evaluation by a radiation oncologist, and preferably one who's treating a lot of thoracic tumors to discern whether their volume of disease can be treated to 60 gray with the idea of chemoradiotherapy followed by immunotherapy. There are Stage IIIC patients based on burden of disease or comorbidities who might not be appropriate or best managed with chemoradiotherapy. But in my experience, most patients with Stage IIIC disease can receive curative intent chemoradiotherapy.
Based on your experience, can you give an example of a patient with Stage IIIC non-small cell lung cancer who would be treated with curative intent by radiation oncologists?
As I was alluding to, not all Stage IIIC patients are created equally. Certainly, you could have a best case scenario where a patient has an upper lobe primary that perhaps is 5.5 centimeters and is T3, and they have 4R and 4L lymph nodes. So technically, they have N3 disease, but the radiation field is relatively confined. Those patients probably have a prognosis more in line with a Stage 3A or 3B patient and would be treated by most radiation oncologists with curative intent chemoradiotherapy.
What about a patient with an upper lobe tumor and supraclavicular nodal involvement?
Supraclavicular nodes are something we see fairly frequently with patients with upper lobe tumors. Again, these patients should be evaluated by a radiation oncologist, especially if the supraclavicular node is in close proximity to, as you said, an upper lobe tumor. While it is N3 disease and therefore Stage IIIC disease, they often can be encompassed in a fairly modest radiation field. And again, treated with chemoradiotherapy, again, to be followed by immunotherapy.
I send all Stage 3 patients to a radiation oncologist. And the ones I don't are presented at tumor board, but even those are very uncommon. As Dr. Kruser said, I'm not the one that can make a decision about too big a radiation field, what can or cannot be done, especially with modern IMRT techniques.
What advice would you give to community practices for getting patients with unresectable Stage III non-small cell lung cancer through this regimen?
In my experience, I find that it's super helpful to manage expectations. So I think educating patients on what to expect is the best thing that we can do.
I agree with Dr. Spira. It's important to have good expectations, not only for the patient, but also for the family. So letting the patient's family know that it's going to be a tough last few weeks and that they're going to need to ramp up their level of support can really help patients get through the most challenging part of the chemo radiation.
Look for other episodes from TOPS that highlight practical perspectives in managing lung cancer.